Hey everyone, so this video will talk about IV fluids in pediatrics in cases of hypernatremia. So we start with hypernatremia. What is hypernatremia? Is increased sodium. When mild, it's 146 to 149 millimole per liter, and moderate is 150 to 169 millimole per liter, and severe hypernatremia is above or equal to 170 millimole per liter, knowing that the normal sodium is 135 to 145 millimole per liter. Okay, so now moderate to severe hypernatremia can lead to acute brain shrinkage with vascular rupture. It can also lead to hemorrhage, demyelination, and a permanent neurological injury. So, infants and small children are more vulnerable to hypernatremia. And that can be due to two main causes. The first one is greater insensible losses. They have greater insensible losses. And the second one is their inability to communicate their need for fluids or access fluid independently. Now, as for the causes for hypernatremia, we've got water deficit, the most commonly caused by gastrointestinal loss through diarrhea or stomal losses, skin loss, excess sweating and burns, renal losses, osmotic diuretics, diabetes mellitus, polyuria of acute tubular necrosis, and inability to obtain water, including breastfed babies, due to inadequate milk supply. Less common causes of water deficit are diabetes insipidus, central nephrogenic systemic disease, or drugs. Increased insensible losses, and impaired thirst mechanism secondary to underlying neurological abnormalities or hypothalamic dysfunction. Okay, the other cause for hypernatremia is sodium excess. So the first one is water deficit, the second one is sodium excess. And that can be due to ingestion of high sodium, inappropriate formula concentration, high osmolality rehydration solutions, or salt poisoning. Or it could be iatrogenic through hypertonic saline and sodium bicarbonate, and hyperaldosteronism, primary as in cons and secondary as in CCF, nephrotic syndrome, and steroids, where CCF refers to congestive cardiac failure. Now we're moving on to examination. The first thing we do is assess hydration status. Now we look for non-specific initial signs such as irritability, restlessness, or weakness. This can be followed by vomiting, muscular twitching, fever, or doughy skin. Doughy skin is, from its name, the skin is like a dough. It's soft and like full of fluids. And high-pitched crying and tachypnea can be seen in infants. Now I will be discussing the severe signs of hypernatremia. First one is altered mental status. The second one is lethargy. The third one is seizures. The fourth is hyperreflexia. And finally, coma. Now we're moving to investigations. They are recommended if sodium is above or equal to 150 millimole per liter. We do urea, electrolytes, and creatinine, calcium, magnesium, phosphate, and glucose. If there is hypoalbuminemia, albumin is below 30 grams per liter, blood gas sodium level is more reliable. Now, initial paired serum and urine sodium and creatinine and osmolality is ideal. So it's ideal to have all these, but if results will be delayed or can delay treatment, urine dipstick for a specific gravity can suffice. It will give an indication of urinary concentration, and treatment shouldn't be. Evaluation of hypernatremia using paired serum and urine osmolality. If urine osmolality is less than serum osmolality, that indicates urinary concentrating defect, such as central diabetes insipidus or nephrogenic renal disease and osmotic diuresis. If urine osmolality is more than serum osmolality, it indicates intact urine concentration, where the causes here are GI losses, increased insensible losses due to burns, or excess sodium intake. And now for management. We first of all treat shock as a priority, of course. There is a video about the resuscitation in details. I'll link it down below if you need it. Once circulating volume is restored, the rate of sodium correction should be slow. No more than 0.5 millimole per liter per hour or 10 to 12 millimole per liter per day. Now, in severe hypernatremia, where the concentration of sodium is more or equal to 170 millimole per liter, this is a medical emergency. Refer to a tertiary center and contact ICU immediately. Okay, so now we'll discuss the management of mild hypernatremia and moderate hypernatremia. We start by mild hypernatremia, where the sodium concentration is 146 to 149 millimole per liter. We manage the underlying cause and repeat urea, electrolytes, and creatinine in 4 to 6 hours. As for moderate hypernatremia, when the sodium concentration is 150 to 169 millimole per liter, the first thing we do is concentrate on the underlying cause and try to treat it. The second thing, we restrict and record oral fluid intake, as thirst can be excessive. We cease any feed fortifications, monitor fluid status with urine output and repeated weights. We weigh at least daily and up to 6 hourly. We repeat urea, electrolytes, and creatinine 1 to 2 hours after initial management, and then 4 to 6 hourly if the sodium level is decreasing at an appropriate rate. Okay, so now, in cases where the decrease is too rapid, which is more than 0.5 millimole per liter, we should cease or reduce the rate of fluids and seek expert advice early. Okay, if hypernatremia worsens or is unchanged, in this case, we also seek expert advice, but to ask about hypotonic solutions. We should also monitor neurological status closely. Now we'll move on to the treatment of moderate hypernatremia due to water deficit. So as we mentioned earlier, we've got two causes, water deficit and sodium excess. So now we'll concentrate on this part. As we mentioned in previous video, I will link it below if you need it. The total fluid requirement equals maintenance plus replacement of deficit plus replacement of ongoing losses. The detailed calculations will be linked in a video below. So we replace water deficit over 48 hours, and once urine output is established, we can add potassium to IV fluid prescription. We should also treat diabetes insipidus with endocrinology input if we need it. Now, if seizures occur, the first thing we should consider venous sinus thrombosis or cerebral infarction. We should consider imaging, contrast CT scan, and we should contact ICU. May need a hypertonic saline to slow a rapid decrease in sodium level. There's a table that you can use. I'll add the link to the table also in the description box. It's an easy table for just quick calculations. Okay, now the treatment of moderate hypernatremia due to sodium excess. First of all, decrease excess sodium intake. The second point is we get expert advice, as may need hypotonic fluid or dialysis if overloaded. In severe hypernatremia above or equal to 170 millimole, we require expert input. Okay, so that's it for this video. Thank you so much for watching. If you have any comments, please leave them below, and like and subscribe to my channel.